Welcome back to NephBytes. Every episode so far has revolved around ADH being on when it shouldn't be, SIADH, or ADH being appropriately on in response to the wrong upstream problem, as in salt wasting. The framework has been, high urine osmolality means ADH is active, and then you work out why. Today, we flip that entirely. Today we're talking about hyponatremia, where ADH is suppressed. The kidneys are doing exactly what they're supposed to do. The urine osmolality is below 100, maximally dilute or close to it. The feedback loop is working, and the patient is still dangerously hyponatremic. This is hyponatremia at its most counterintuitive. The kidney is not the problem. Something else is overwhelming it. Either the water intake is so enormous the kidneys simply can't keep pace, or the kidneys don't have enough solute to carry the water out even when they're trying as hard as they can. These disorders, water intoxication, exercise-associated hyponatremia, primary polydipsia, beer potomania, and tea and toast hyponatremia, all share that same lab signature. Hyponatremia with a dilute urine. And because the urine is dilute, they can look nothing like SIADH, which makes the diagnosis more straightforward, once you know to look for it. The harder part is knowing how dangerous the acute presentations can be, and understanding why the treatment for low solute states is completely different from anything we've covered so far. Let's start with the most dramatic end of this spectrum. Case 1. Acute water intoxication. A 22-year-old woman is brought to the emergency department from a college event. She participated in a water drinking contest. Contestants were told to drink as much water as they could in 1 hour without urinating. She's now confused, nauseated, and vomiting. No drugs, no alcohol. Sodium is 119. Serum osmolality 250. Urine-specific gravity 1.002, nearly pure water. That urine tells you everything. ADH is suppressed. The kidneys are pouring out dilute urine as fast as they can. They are responding correctly. The problem is intake. Normal adults can excrete roughly 20 liters of water per day. That sounds like a lot. But the maximum urine flow rate the kidneys can sustain is only about 800 to 1,000 milliliters per hour. So if someone drinks faster than a liter an hour, the kidneys physically cannot keep pace. Plasma volume expands. The sodium gets diluted. It falls fast. This patient has been drinking for an hour straight without urinating. Her kidneys never had a chance. Now here is the distinction that matters most in this case. She has acute hyponatremia, onset within hours, and that changes everything about how we think about correction. In chronic hyponatremia, the brain has had days to adapt. It extrudes osmoles, taurine, glutamate, other organic solutes, to reduce intracellular swelling and protect itself. That adaptation is what makes rapid correction dangerous in chronic hyponatremia. If you correct too fast, the brain is now in a hypertonic environment relative to its adapted state. Water leaves brain cells, and osmotic demyelination can occur. In acute hyponatremia, the brain has had no time to adapt. There is no intracellular osmole loss. Rapid correction does not cause osmotic demyelination. The strict limits we follow in chronic hyponatremia, 8 milliequivalents per 24 hours, do not apply here. But the risk in the other direction is real. A sodium of 119 with confusion and vomiting means cerebral edema is already developing. Untreated, this can progress to seizures, respiratory arrest, herniation, and death. Cases have been reported from water drinking contests. This is not benign. The treatment is a 100 milliliter bolus of 3% saline. Raise the sodium 4 to 6 milliequivalents within the first 6 hours to reverse cerebral edema. Repeat if neurologic symptoms persist. Once she stops drinking, her kidneys will self-correct the rest, and that rapid self-correction in the acute setting is safe. Treat first. Let the kidneys catch up second. Case 2. Exercise-associated hyponatremia. A 38-year-old woman collapses at the finish line of her first marathon. By mile 20, she had a headache and nausea. At the medical tent, she's minimally responsive. Blood pressure 110/80, heart rate 95. Point-of-care sodium is 115. This is severe exercise-associated hyponatremia, and it's more common than most clinicians realize. The incidence reaches 18% in marathon runners and climbs higher in ultramarathon events. The pathophysiology stacks several mechanisms at once. During prolonged exercise, sodium is lost through sweat, creating some true volume depletion. Reduced renal blood flow impairs the kidney's ability to dilute urine. ADH is stimulated both by exercise physiology itself and by angiotensin II from the reduced renal perfusion. And critically, the runner has been replacing losses with hypotonic fluids, water, dilute sports drinks, every cup station, every mile. The Boston Marathon study identified the key risk factors. Weight gain of more than 3 kilograms during the race. That's the sign of net fluid retention despite sweating. Race duration over 4 hours. Drinking at every aid station regardless of thirst. Female sex and extremes of BMI also increase risk. The treatment is identical to acute water intoxication. 100 milliliter bolus of 3% saline peripherally. Repeat if neurologic symptoms don't improve. For a conscious runner who can swallow, 4 bouillon cubes dissolved in half a cup of water delivers roughly 180 milliequivalents of sodium per liter, essentially oral hypertonic saline. What you do not give: normal saline, which is too dilute and too slow to reverse cerebral edema in an acute symptomatic patient. A slow infusion of 3% saline, in a field setting with an unstable patient being transferred, a bolus is logistically and physiologically superior to a drip. And 5% dextrose would obviously make things significantly worse. Desmopressin has no role here either. ADH is already suppressed. There's nothing for desmopressin to add. Now let's shift to the low solute syndromes. Same lab picture, hyponatremia with dilute urine, but a completely different mechanism and a completely different treatment. Case 3. Tea and toast hyponatremia. A 30-year-old woman with bipolar disorder presents with fatigue and cognitive slowing over the past month. She's on lithium. She follows a strict plant-based diet and has a BMI of 17. Sodium is 126. Serum osmolality 261. Urine osmolality 92. Dilute. Urine sodium 25. Urine volume 2.8 liters per day. BUN is 4. ADH is suppressed. The kidneys are making dilute urine. This is not SIADH. But the urine volume is only 2.8 liters, not the massive polyuria you'd see in someone drinking compulsively. And that BUN of 4 is strikingly low. It tells you there is almost no protein intake. So what's going on? Here's the physiology, and it's worth slowing down for because it's elegant and counterintuitive. The kidneys can dilute urine to a minimum of about 65 milliosmoles per kilogram. That's their floor. But water excretion isn't unlimited at that floor. It's proportional to the solute being excreted. The kidneys carry water out alongside solute. No solute, no water excretion. You can calculate the maximum water excretion with simple math. Her daily solute excretion: urine osmolality 92 times urine volume 2.8 liters equals 258 milliosmoles per day. Normal is 600 to 900. She's generating less than half the normal solute load. Maximum water excretion, daily solute divided by minimum urine concentration. 258 divided by 65 equals about 4 liters per day. If she drinks more than 4 liters, which is not difficult if you're eating very little and drinking throughout the day, the excess water cannot be excreted. It's retained. The sodium falls. And with a BMI of 17 and a restrictive plant-based diet, she may have an eating disorder driving the low solute intake. That's important to address as part of treatment. The treatment here is not fluid restriction, and it is not tolvaptan. ADH is already suppressed. Tolvaptan blocks ADH at the collecting duct, and if ADH isn't there to block, tolvaptan has nothing to act on. It simply won't work. The treatment is to increase solute intake. Protein supplements are the best option because they address the nutritional deficit while also providing urea, a solute that drives osmotic diuresis and increases water excretion capacity. Oral urea, or salt tablets, would also increase the solute load if protein supplementation isn't feasible. One critical caution. If you give protein or solute and simultaneously restrict fluids aggressively, the sudden increase in solute excretion capacity drives a brisk water diuresis. The sodium can overcorrect rapidly. In patients with severe hyponatremia, consider running desmopressin concurrently to control the rate of correction while the solute is being restored. Beer Potomania is the same mechanism in a different package. Large volumes of beer, which is mostly water with very little protein, very little electrolyte, and very little nutritional content, combined with little to no food intake. The daily solute excretion drops dramatically. Even maximally dilute urine can't excrete the water load. The sodium falls. Same treatment. Increase solute. Do it cautiously. Watch for overcorrection. Case 4. Primary polydipsia. A 42-year-old woman with hypertension and bipolar disorder on stable doses of hydrochlorothiazide, amitriptyline, and lithium. Sodium is 121. Urine osmolality 90. Maximally dilute. 24-hour urine volume is 8 liters. This is primary polydipsia. The urine is dilute. ADH is suppressed. The kidneys are responding correctly. But unlike the tea and toast patient, her daily solute excretion is normal, about 720 milliosmoles per day. She has plenty of solute. The problem is not solute deficiency. The problem is pure volume. She is drinking so much water that even the kidney's maximum excretory capacity, driven by normal solute, cannot keep up. So why does she have hyponatremia when most compulsive water drinkers maintain a normal sodium? Because 2 things have compromised her excretory capacity. Her creatinine is 1.6. Reduced GFR means the kidney handles less filtrate per minute. And she is on hydrochlorothiazide, which directly impairs the diluting segment of the nephron. The thiazide reduces the kidney's ability to generate maximally dilute urine. The combination of massive intake, reduced GFR, and impaired diluting capacity tipped her over the edge that most polydipsic patients never cross. The cause of the polydipsia is also worth investigating. Anticholinergic medications like amitriptyline cause dry mouth, which drives thirst and water intake. That's a modifiable target. Psychiatric compulsion to drink is another mechanism seen in bipolar disorder and schizophrenia, sometimes requiring behavioral intervention. The treatment is to address the water intake, stop the thiazide, It's impairing the very mechanism the kidney needs to clear the excess water. Investigate and address the cause of the compulsive drinking. Increasing solute intake won't help here the way it does in beer Potomania. She already has enough solute. The problem is on the intake side. Let me pull this together into a framework. When you see hyponatremia with a dilute urine, osmolality below 100, ADH is suppressed and the kidney is doing its job. The differential narrows to 3 questions. First, is intake overwhelming capacity? Think water intoxication, exercise-associated hyponatremia, or primary polydipsia. The urine volume will be high. In the acute symptomatic setting, treat with a 3% saline bolus. Otherwise, reduce intake and address what's driving it. Second, is solute intake too low? Think tea and toast hyponatremia, beer potomania, or eating disorders. The urine volume is moderate, but calculate the daily solute excretion. Urine osmolality times urine volume. If it's below 300 milliosmoles, you have your answer. Treatment is increase solute, protein supplements, oral urea, or salt tablets. Be cautious about simultaneous fluid restriction. It can drive overcorrection. Third, is excretory capacity compromised? Think reduced GFR or thiazide use layered on top of high water intake or low solute. Fix what you can. Stop the thiazide, address water intake, provide solute. The goal is to restore the mismatch between what's coming in and what the kidney can handle. One last point worth making explicitly. Because the urine is dilute in all of these disorders, they are easy to distinguish from SIADH at a glance. A urine osmolality below 100 essentially rules out SIADH in a euvolemic patient. But they are not benign. The acute presentations, particularly water intoxication and exercise-associated hyponatremia, can be rapidly fatal if untreated. The dilute urine is reassuring about the mechanism. It is not reassuring about the severity. Next episode, we close out the hyponatremia series with the special populations, cirrhosis, and advanced kidney disease requiring dialysis. These are the cases where the standard algorithm gets complicated, where your instincts from the last 6 episodes may steer you wrong, and where the stakes of getting the management right are the highest. Thanks for listening to NephBytes. I'll see you next time.